So welcome to Book Chat. Yay. I'm very happy to be here today. I'm Patricia Dubroff. I'm with Assisting Hands Home Care, and we provide certified nursing aides for your family and loved ones and friends and cousins and grandparents all over Maryland and Virginia. So if you have anything you want to talk about home care with me, please feel free to do so. I'll put my information in chat. And I want to welcome our Book Chat author today, Bonnie Friedman, who is a neighbor in Montgomery County and is retired from a very wonderful career in the U.S. government in the information office, and is now taking her fabulous book around the country and getting rave reviews. So her book is called Hospital Warrior, and it's a story told in 3 parts, and we're going to go back and forth and talk about it. So Bonnie, welcome to Book Chat. Tell us.
Thank you. Thank you. It's a delight to be with you.
Tell me about how you started this concept of Book Chat. Book Chat, listen to me, Hospital Warrior. Tell me about how Hospital Warrior became in your head.
Well, I had a long-standing career in the federal government, as you mentioned. I'd always been in communications, and I'd always been focused on the public service side of things. So that was my orientation. During my career and over the course of our marriage and raising our children, Bob had a series of hospitalizations, sometimes very serious, some of them life-threatening. And in a 24-year span, he had 14 different episodes of being in the hospital. A couple of those were maybe garden variety, if you will, but some of them were really quite serious and a couple very unusual. So my life was a series of stop and starts between his illnesses, raising our kids, and keeping my career going. And all that while, I kept learning more and more about how a hospital works, what kind of a bureaucracy it is, and who's in charge of what. And most importantly, what buttons do you have to push to get things done in that kind of a setting? And it was not a formal study by any means on my part. It was really quite experiential. But over all this long period, I just kept learning and learning. Bob's last hospitalization was actually a series of 2 different hospitals and a nursing home in between, and altogether a 3-month stretch of very serious and at one point quite life-threatening illness. And when he finally recovered from all that and started to heal, I realized, first of all, at that point, I had my own business. I had left government. I had a consulting business. The business had totally flatlined. He lived, the business did not. And I was going to try to restart things, and I found that wasn't my passion. At that point, I was just literally brimming over with this desire to share how much I had learned, so that like I said, I was always public service focused. I wanted to give other people that information so they could learn how to advocate in a hospital setting.
So what kind of time period did you devote to writing the book? I mean, were you one of the people who said, I'm going to write this book and I'm going to be done by June? Or did you kind of start and stop? What was the process?
Well, it was more of a start and stop. I started the book. I quickly was able to get an agent, and that's the first big hurdle in publishing these days. And the agent would give me suggestions about going forward, but she'd also say, don't go too far ahead because a publisher may want to influence how the book evolves. So it was very organic and very much of a stop-start process. I just kept writing, and I felt if I needed to revise, I would. In the end, I had a small indie publisher who I loved, and who was very happy with the book as it was. They did some minor editing, but over almost a 2-year period, I was writing off and on.
That's great. So the book is divided into 10 chapters.
Mhm.
And what I like about each of the chapters is not only does it offer you the story of Bob's journey and Bonnie's ability to function at the hospital level and figure it all out, but it also gives kind of the practical step by step. And then there's a piece about like hot tips. I
Yeah,
love the hot tips. Very cleverly done. So the first chapter is taking care of yourself. And I think that's, to me, the place where a lot of folks who are worrying about loved ones in the hospital forget. They're not
absolutely.
sleeping, they're eating crappy vendor machine food or whatever, and it gets way out of hand. And the more they get uh, anxious about their family members, the less they're taking care of themselves. So, do you want to talk a little bit about that?
You know, I start the book with the analogy to the message you get on an airplane when the airline steward or stewardess comes on and tells you that in the event of an emergency, the first thing you should do with your air supply is to fasten your own. And then only when your oxygen mask is in place do you turn to anyone else to help, including your children. And I used to think that was just counterintuitive to me. How would I not take care of my children first? But the lesson in this is if you aren't taking care of yourself, you cannot take care of anybody else. It is so important that you get your sleep, that you eat properly, that you get little breaks from the hospital, that you find whatever ways you need to find to recharge your batteries, even if it's a little bit at a time. And I will tell you, this is not easy. And it was not something I came to naturally. It took a lot of, shall we say, encouragement from family and friends for me to learn to do this and to accept help from others. There are a lot of people around you who want to help you. They don't always know what to do, and they're not even sure how to ask, but you need to learn to accept good offers that come your way and to ask for the things that you want, which I found very, very difficult. So there's some real lessons in there, but the bottom line is you have to find a way to make sure your basic needs are getting met. And those are emotional as well as physical. Or you won't do your loved one any good.
So, I wanted to read a little section in here. Do you have your book with you too? Oh, good.
Of course.
Yay. I forgot to ask you that before. I was like, I think she has her book with you. But I was looking at, No Time Like the Present on page 26. And it says, stay as calm as possible. If you're feeling apprehensive, walk away. I'm just paraphrasing, or not paraphrasing, I'm just reading the short version. Find out as much as you can about what's happening. If a long wait is expected, make sure you get something to eat and make backup plans. If you have children or pets, they're going to need attention in case you can't get home right away. And then you mentioned before calling a family friend and also seeing if somebody can come and be at the hospital with you. There's nothing like just having somebody else there to help make you feel better. And then I love your tip. Don't try to be Superwoman. Do as much as you can within reason. Everything doesn't have to be done at once. Hugely important.
You know, Mary, I liked your comment at the beginning about wanting to be prepared for the if and when someone has to go to the hospital. I think of this whole book as being something like a fire drill. Nobody wants to think that their house is going to ever be on fire, or their office, or any other place they might be. But they also want to know that if it happens, they're prepared. They know what to do. And so that's what Hospital Warrior is about. Learning in advance what you can do, thinking about some of the perhaps unthinkables, and just being a little bit prepared before anything ever happens. And then if it does, you have this as a guide to get into all of the details about the particulars of the situation. But you don't have to do everything at once. And I think it can seem overwhelming when you're in the midst of it all. So learning to take some baby steps is really, really important.
So at some point and I think it's in the second chapter, you start talking about the difference between a planned hospital visit and the unplanned. And I think for most people, when they think about hospital, they're not thinking about a planned visit. They're thinking more about that ER time. And there's a whole section in here about emergency room and how the different staff people can be your advocate and who the right people are to ask for help. Do you want to talk a little bit about that?
Sure. You know, like you say, we often think in terms of an emergency trip to the hospital. In fact, a lot of visits to the hospital are planned, maybe short term, but they are planned. You have a surgery scheduled, for example, and you have time to think it through and get all your paperwork in order, and you can go in a more, I'm not going to say it's relaxed, because nothing about the hospital is relaxed, but you're at least more at peace of mind in terms of being prepared. When you go in through the emergency room, there's so much that is completely out of your control. And whether you're the patient or the family member, you're really, you're in a whole new world. And in this world, there's all kinds of strange sounds, and there may be sick people moaning, and the patient may not be able to get something to eat or drink, and it may be cold or hot. There's so many things beyond control. And overarching all that, there's this incredible anxiety about what's going on and is how, you know, what's happening to the patient, or if you're the patient, what's happening to me. So one of the things that I think is important here is to try to get a little bit of a lay of the land. Who's in charge of what? And in the emergency room, first of all, one thing you should know is that often the staff in the emergency room is not the hospital staff. They're very often contracted out as employees to provide all of the ER service that's
Not
required.
contracted if they're employees.
So, pardon me?
I'm sorry. Go ahead.
So you just need to know they're not necessarily on staff. It doesn't mean they're not qualified. It doesn't mean they don't know what they're doing, but they're not necessarily the staff of the hospital. That said, there are doctors, there are different kinds of doctors. You may be assigned to an emergency room doctor, emergency department, somebody who specializes in emergency medicine, and that may be the doctor overseeing your case. If you're going to be admitted, and I want to come back to that issue later on if we can, but if you're going to be admitted, then you may be assigned to a hospitalist. And that may in fact be somebody who works for the hospital, not the emergency department. but that hospitalist is not going to be your primary care physician. That will be the doctor who manages your case while you're in the hospital. Very different from the old days when your primary care physician would get a call that the patient's in the hospital and that doctor would come to see you. That rarely, if ever, happens anymore.
And what about which hospital to go to for an emergency or where to go? I mean,
Yeah,
anymore, if it's, a cut or a bruise or something, you're more likely not to go to the hospital, but to go to an emergency center.
correct, correct. If you know, for example, that you have a cardiac disease, and if you're going to have a problem, it may in fact involve a cardiac condition. You want to check out what are the hospitals around me that are specializing in cardiac care, that have the higher ratings in cardiac care. But very honestly, if it's a true emergency, you need to get to an emergency department as quickly as you can. In some cases, you may get transferred after you've gone through those initial steps. And you may not want to spend too much time deciding, should I go here or should I go there? If you think you're having a heart attack, get to a hospital. But there are specialty hospitals. There are hospitals that get higher ratings than others. It's certainly worth knowing that this hospital is highly rated in cardiac care, but that hospital is more highly rated in oncology or whatever it may be. Know what the hospitals around you are specializing in and highly rated for. But in a true emergency, get yourself to a hospital. Now, back in the emergency department, you're going to have nurses as well as doctors that are going to be assigned to the patient's care. And honestly, if it's not life-threatening, you're going to be doing a fair amount of waiting there, and that's very hard. One of the things an advocate can do is look after just some of the patient's comfort during that long waiting time. Is the patient cold? Go ask, not just for an extra blanket, ask for a heated blanket. Ask if the patient's allowed to eat or drink. If they're anticipating the possibility of surgery, they may say nothing by mouth, but it may be okay to have liquids only or ice chips. So you can find out what's allowable and attend to the patient's comfort level as best you can. You can ask what to expect. You may go up to the nurse at the desk and say, we've been here a couple hours. I don't really know what we should anticipate going forward. Can you give me an estimate of when we might see a doctor? So that at least gives you a time frame. It's so much better to know it's going to be another 45 minutes and we just have to settle in and wait than keep looking at your watch thinking, when is this going to happen? So it's a very surreal time in the whole hospital experience. And you have to find the ways you can make the best of it. And I'm speaking now as the advocate. The patient is really disadvantaged in all this. Very, very hard for the patient to get the attention they need, unless it's life-threatening, in which case they will get all the attention they need.
Yeah. So you have a chapter in here called Understanding the Special Units, and you compare it to traveling to other planets. I think we're all thinking about traveling to another planet right now. Do you want to read that that first paragraph? I think that's really cleverly written. And just to give a style of how you write. 77.
Thank you. Sure. Visiting outer space. If visiting the hospital seems like travel to a foreign land, then time in some of the special units may seem like a trip to outer space. These areas are designed to meet specialized needs such as elder care, intensive care, coronary care, and infectious disease. Each has its own practices, procedures, and requirements. Some even have a dress code. Understanding the unique features of a special unit is important if your loved one is a patient there.
So when you talk about these special units, what kinds of things come up for you? What are like the automatic special units that you would think of?
Well, the first one that comes to mind is the post-op. So if the patient's having surgery, they're going to be in a post-operative recovery room immediately following surgery. And depending then on what kind of surgery they've had and the extent of it, they may either go to a specialized surgical unit, such as coronary care. If they're very ill, and have had very serious surgery, they may go to the intensive care unit. If there are specialty requirements associated with the kind of surgery and treatment they're having, that will dictate what kind of post-operative care they're going to get and where they're going to get it. Sometimes there's a general surgical ward in the hospital and you're recovering from your appendectomy, things are going fine, you're going to go to a general surgical floor for that kind of recovery, as opposed to some of these more specialized areas. And perhaps if you're in a life-threatening condition, to intensive care or a very specialized kind of care.
So Bonnie, if somebody doesn't have an amazing partner like you, a spouse who's willing to be the champion advocate, are there other resources for folks to hire a person like that? How does that work if you're all alone?
Yeah, and this some of this advice transfers over to the patient as well as the advocate. So there are resources, and oftentimes if you're the patient, you don't have the wherewithal to really get involved in this in the moment. And we can talk about preparing for that sort of possibility. But if you're the advocate and you feel like this is beyond me, I need help, I can't be here 24/7, you can hire a private nurse or nurse's aide to help spot some of that time and give you a break from the hospital if you don't have someone else who's not only willing to step in, but able to do some of the things that need to be done.
I guess
You can
I was
hire,
thinking more about like a case manager. Is that
right.
okay?
Yeah, absolutely. We're on the same.
Okay.
You can hire a geriatric care manager to oversee all of the services and resources that need to come together for both extra help in the hospital as well as what the patient may need when they go home. And I'll bet Patricia's willing to talk to you about some of the things that are available to do that. In the hospital itself, there are social workers. Often their focus is on the discharge planning process. But if you need help with, again, pulling these resources together, they may be able to help you. There's also the professional patient advocate, and most hospitals have that now. They used to call it the ombudsman, but it's an updated term and it comes with a more rigorous background and study behind it. So you can actually go to school and get a degree. I think it's an associate degree, I'm not positive, but you can get a specialized degree in patient advocacy. And so that's somebody who works for the hospital, but specializes in the particular needs of the patient. And that can be anything from, I don't understand what my doctor is telling me, and they won't take the time to answer my questions, to I keep asking for a specialized diet because I can't have salt and they keep sending me high salt meals. or anything in between. But the patient advocate office can often be of help to you. And last but not least, your bed nurse. I think the nurses are honestly I call them the heroes and the sheroes of the hospital. They are so well trained and so well equipped to advocate for their patients. A lot of times that skill gets kind of lost in the bureaucracy of a hospital, but first and foremost, that's what nurses are. They are advocates. And so enlisting their help, saying, look, I don't have what I need. My husband, my wife isn't getting what they need. I don't know how to make this happen. Please give me some advice. So those bed nurses can be real lifesavers.
So one of the programs that we run is called What's Your Plan? And we do an interview with specialized folks in the field. And last week we did an interview with Susie Murphy, who's the owner of Deborah Levy Elder Care. And they actually have started a program where for an annual fee, they will do an assessment and then update that assessment. And then God forbid you should need them. For instance, if you go to the hospital, they can then be called immediately to come and be with you in the hospital. And I think that's kind of where that's a sign of the times, where we have a lot of elders aging in place alone, doing really well, but concerned that what if I have to go to the hospital? Who's going to be there for me? My daughter's, 6-hour flight away, or my, cousin doesn't walk anymore, or whatever it is. And so there are some really cool programs like that in our area. So if anybody has questions about those, feel free to ask.
I did a blog on this issue a while back because there are people who are doing well aging in place, and they know there's a possibility down the road they may need to go to the hospital and they don't have family nearby. So one of the things you can do is research, find out what are the resources available to me. And the program that Patricia's mentioned by the Deborah Levy Associates is a great possible resource for people. You can also just find out what are the possibilities that I might want to tap into and have that information available. What is a nursing agency that I think is really good and I could have to call upon if I need it? What about the resources that you can call Patricia to learn more about and what they offer? There are all the types of things. You can just collect that information, have it available, and if you need it, you'll know where it is, as opposed to trying to figure it out in the midst of your hospital stay.
Yeah, I was noticing that Janet Gritz is on the call, and she's an excellent resource for anyone who's a stroke survivor. So, when it comes to reaching out to folks, there's so many great people out there, especially in our area. I know that other friends and family in rural areas have a much more challenging time finding resources.
Mm-hmm.
So do you want to talk a little bit about how hospital visits and the world has changed since COVID and what you might recommend?
Right. This is not only timely, it is top of mind for so many people.
Mm-hmm.
And we're all trying to figure out how do we make the best of this situation. Most hospitals are not allowing visitors, and they some hospitals will sometimes make an exception. It's a individual hospital choice, and it's dictated by whatever the rules are in the state or municipality, as well as obviously the caseload in the area. So assuming you can't get to inside that hospital, You have to figure out first and foremost how to make the most of what are limited options that are available to you. And I think, you know, your phone is your best friend, both for actual phone calling as well as any online platforms that you can take advantage of. Obviously, your laptop as well. But I would make it a point to be able to use that phone to know who's the bed nurse or nurses, given the staffing turnover that takes place in the course of a day. Who's in charge of what when? Who's the attending physician? And, you know, that is sometimes hard to figure out even under the best of circumstances. If it's a teaching hospital, there may be a whole array of people who are called doctor when in fact they're at different levels of being or becoming a doctor. There's one doctor in charge, that's the attending, and you want to find out who that is and make sure you know how to reach the attending physician. You also want to try to figure out how can you get updates without being there? And that's going to vary considerably, really based on the preference and the time limitations of the doctor directly. Sometimes being able to just call the doctor's office and say, I need an update. I don't know what's going on with my loved one. What's the time I can call to speak to the doctor? Can I call at 3? Can I call at 4? Find out when can I make an appointment, essentially, to call and get that information. If you're able to talk to the doctor while they're doing rounds, it's early in the morning, but if you can get that doctor to phone you in to rounds, that's where you're going to learn the most about what's happening with the patient. So that option is something you might want to explore as well. And you want to find out if there are any video chat apps, be it Zoom or Duo or Google Meet, that you can employ to have conversation with the doctor and with your patient as well. See if the patient has a phone at bedside and is able to use any of these platforms, that can be very, very helpful too. So try to take advantage of the technology. When you're able to talk to a doctor, make the very best use of that limited time you have. I always advise people have a list of questions and make sure the most important ones are at the top of the list. You don't want to use up your few minutes asking the secondary level of question and the doctor says, I'm sorry, I have to go. And you're left thinking, but I didn't ask the most important thing. So make sure you're organized with that and you're able to make the best use of that time. It's very difficult during this period. And for patients that have special considerations, this is a very serious issue. If they're not able to speak up for themselves at all because of their illness, if there's a language barrier or any cognitive impairment that's either preceded the illness or is going along with the illness, makes it really, really difficult, if not impossible, for the patient to have the meaningful conversation with the doctor that's necessary. So you're being able to find the way that will work. And again, you're going to need to be as flexible as you can with the doctor's preference to get the entree that you need. But you also have a right to insist on getting some important questions answered. So be nice, be pleasant, be polite, but be firm. You have to know what's going on and you have every right to insist that you be kept in the loop.
So one of my favorite sentences in your book is actually says sometimes all the good intentions and careful planning give way to just doing your best, and that's all we can do. And I think that's, you think about the complexity of a hospital setting in normal times, non-COVID times, and now where really they're only allowing in folks on a case-by-case basis, and you really aren't going to get in there. I mean, I've had so many friends and colleagues talk to me on our death cafe about how they never saw their mom pass because they couldn't get there. They weren't allowed in. That's shifted a little bit at end of life. They've changed a little bit of those rules, at least at Suburban and MedStar Montgomery. I know about those two. I don't know what Shady Grove's doing of late. But in our area, I think it's, we're so fortunate to have some excellent hospitals right here in the area. But you also just have to give yourself a huge break and say, you know what, I'm not going to be able to advocate as well for my loved one. And if you're the one who's in the hospital, who are you going to call? You're going to need to call a professional because they're the only ones that are going to be allowed in. When you call for private duty, home health aid, you're basically getting a professional in this place who can use a phone, who can help you advocate for yourself or for your loved one.
I did a blog not long ago on this issue of how to advocate during COVID. And I'd be happy to send that to you, Patricia. And if anybody wants it, they can certainly get it easily.
That would be lovely. We'd love to see that.
Happy to do it.
Does anybody have any questions? We're kind of winding down. And I just want to.
I do, but go ahead.
No, go ahead.
Bonnie, you mentioned earlier that you might be able to come back to this point, and I think it's an important one, about when someone's in the ER, when they are actually admitted to the hospital or not, for the observation versus admitting. Could you comment about that, please?
Yes, thank you for bringing that back around. People think if they're staying overnight, they've been admitted to the hospital, and that is not always the case. There is a category called observation, and it is not formal admission. It may not affect the quality of care. The patient may still get excellent oversight and care during that period, but it'll affect the hospital bill. And so it's very important to know that status. If you are under observation, staying in the hospital, you're essentially an outpatient. And as far as insurance goes, outpatient services are billed individually. And that means everything from the tongue suppressor to the time of the radiologist who reads your x-rays and anything and everything in between. And you have copays attached to just about everything on that a la carte menu. So you may think you've been admitted. In fact, you've been under observation, and then you get the surprise of a lifetime with a very big hospital bill. So if you're going to be in the hospital, it's important to get that information up front. If you're the advocate or the patient, again, the best of your ability as a patient, ask, am I being admitted as an inpatient or am I under observation? If they tell you you're under observation, I would push it back as hard as I can. You may or may not get anywhere with it, but I would certainly try very hard to get that status changed to inpatient. Hospitals do this for a variety of reasons. And a lot of them get to insurance issues. They get to questions of readmission. They don't like to have patients readmitted under Medicare rules. They get penalized for that. So if you're not formally admitted, you can't be readmitted. You haven't been there yet in that status. It's a complicated and tricky and I think terribly unfair way to deal with patients. But thank you for bringing it back up. It's very, very important.
Yeah.
And I want to say something at the other end about hospitals, and that is discharge planning. And Patricia, is it okay if I take a minute on that? Oftentimes we think of discharge as the process that happens while the patient's sitting in their bed waiting for the wheelchair to come and take them down to the front door. And somewhere during that time, the nurse comes in and reads you the doctor's orders about discharge. That is about the worst way in the world to handle discharge planning. I don't want to be too critical of the nurses who get stuck with just reading that piece of paper at the end. It's more about a system and a process. And discharge planning, from those who are truly expert in this, will tell you it should begin the day the patient actually is admitted to the hospital. There should be social workers that are looking over the patient's situation in terms of their medical condition, but also what are the circumstances at home in terms of stairs and guardrails and children and dogs and loose rugs and whatever else may be involved. So if you do have someone in the hospital and you have the opportunity, really try to get a conversation with the social workers or the discharge planning staff from the beginning, so that that process at the end is not a rushed event and it's not a surprise.
Thanks for that. I want to take a minute. Go ahead, Elisa.
Oh, no, you go ahead. I'll wait for you.
No, go ask your question because I'm going to shift gears. Go ahead.
Oh, I just want to say thank you very much, Bonnie. It's very informative. I hope I sort of don't want to
Never
use
need it.
that information, but
That's what I feel.
good to have it in the back of your head.
Exactly.
I just,
I think, like many things that we read every day, when you read this book and you don't have a specific hospitalization in mind, it becomes a resource book. And I feel more confident knowing that, oh, somebody's got to go to the hospital. I'm grabbing this book. I'm taking it with me.
right.
And I give it to a lot of my clients whose family have repetitive hospital adventures. And they so appreciate it. So it makes a great gift as well.
Okay. So I wanted to ask you, I was under the impression, and please correct me, I don't know, that if you call an emergency, you call for an emergency, an ambulance comes, and then they decide which hospital you're supposed to go to. Is that right? Or, I mean, can you as a patient say, I want to go to this hospital, especially now with COVID, but they, from what I understand, this happened to a friend of mine a couple of months ago, and they told her that she couldn't choose which hospital to go to, that they decide upon availability which hospital they bring the patient to.
Right. By and large, that's true. There may be some situations where there are hospitals equally distant and equally available, and you may be able to say, I prefer A over B. But by and large, the EMTs on the ambulance squad are going to take you most likely to the nearest hospital. But if they know that hospital is overloaded already, then they may take you to the next nearest one. And again, if your medical condition is serious enough that you need an ambulance, you need to get to the hospital you can best and most quickly get to. Sometimes they will move you because once you're there and you've been stabilized, there may be a hospital that is nearby that specializes in something and they want to transfer you for whatever reason. But you don't get to say, take me here, take me there. I think they would tell you it's not a taxi service.
Okay.
Can I just make one comment onto that, Patricia?
Sure.
That becomes really crucial with strokes
Yes.
because not all local hospitals are going to have the same level. There's a new standard, and I don't think any Montgomery County hospital currently meets this new standard
Really?
this past January. And as soon as one does, believe me, that's where I'm going to advise everybody to go if they're having a stroke. It's going to make a big
Janet,
difference.
is Georgetown still
Georgetown,
designated?
and yeah, Georgetown does, and GW, I believe. And there was one in Baltimore, or maybe more, but in Montgomery County, as of a few months ago, that may not be currently true, but as of a few months ago, there was still no Montgomery County hospital, even though there's stroke centers. They're primary stroke centers, but they're not going to be comprehensive, or whatever the next term will be. And it will make a big difference. Once we know that, we need to spread the word, quite honestly.
And
Right.
Sibley, do you know about Sibley?
Again, I'm not really like month to month current, but the last time I was told, which was several months ago, none of the Montgomery County hospitals yet had that advanced level. The difference is there's a second procedure they can do in some cases to stop the clot, to remove the clot physically. And most hospitals don't have that skill yet.
And Sibley's in the district, so you have other options there too.
Yeah.
So
Oh.
I just want to thank Bonnie for joining us today and for once again giving me more insight into the whole hospital world. I learn every time I'm with this woman. She's just got so much information and she just stays so current. So Bonnie does have a blog. She has a podcast. If you want to be part of that, I'm happy to pass on your information to Bonnie on your behalf. I have your email address. If that's okay, just nod. Good, I can do that. And then I wanted to tell you that our next adventure in book chat is going to take a very different turn. We're going into the world of mediators. And the mediators are a fictitious team of equipment that we're all using every day now. Cell phones, laptops, iPads. And the story is about how this little girl is trying to communicate better with her grandfather through emojis. And so she's creating this app, how to translate emojis into real words. And at the same time, talking about how to engage multiple generations in using our devices in a really positive way. It's a very sweet book for early readers. And I think it'll be a lot of fun. The author, Morgan Russo, is an educator and comes to the field with this multi-generational energy. So I think it'll be a lot of fun. Brand new book. Oops, there's things in the chat. Let me see if there's anything that we should share. Janet says, thanks. And you want more info. And yes, don't forget hospitalwarrior.com is the best way to get the book. And if you don't have a copy of it, honestly, it's one of those books you should have on your shelf. It's like, it should be in a to-go bag for, God forbid, moments of hospital worrying.
Let me just say, I put up the Hospital Warrior website because it also is the resource point for all of my blogs and the podcasts I do, as well as other information. So I have written a lot about some of the topics that we've just touched on today. We specifically referenced what you can do now during the pandemic. I have blogs on that, how you talk to the doctors, what you do in trying to speak with doctors during this difficult time. So I will send that one specific blog to Patricia that we discussed, but all of the blogs and all of the podcasts that I do, including one a little while ago, Patricia, with Steve on what Assisting Hands does.
Right.
So there's just a lot more information, and it's all readily available on that website.
Hospitalwarrior.com. And on that note, I'm going to wish you guys all a very lovely afternoon. Thank you for joining us.
Thank you.
And
Thank
I
you.
hope to see you again
so
next
much.
month.